Okay, so this is part three of the brain injury basics course that I wanted to put together because this is my approach in the clinic, and yeah, I just got back from California early this morning. I took the red eye home, and I had the opportunity to work with a really amazing patient, and a lot of these principles apply to his progress. Like I've known about this patient for a while. One of my colleagues, Dr. Daigle, has been working with him, and I've never met him in person. I've never seen him, and I'm always just blown away by people's resilience, their progress with concussions, with really severe diffuse axonal brain injuries. It's just amazing. So, seeing him and seeing how well he's doing, it just reinforced to me how important this stuff really is for people to just know about, even if you're not a practitioner, just know that there are practitioners doing this. He has a full-time speech therapist that's applying a lot of these functional neurological approaches to rehab, and I contribute a lot of his progress to her doing that. So anywho, this is brainstem rehabilitation. So the question is why the brainstem? Well, if there is a brain injury, and even if the brain MRI after a concussion or after a brain injury shows either there is no structural damage to the brain or there is no structural damage to the brainstem itself, it's important to look at brainstem function because of where it sits and some of the important and vital roles it plays in the nervous system. So again, just going back to, building a better brain from a concussion, from a brain injury, the brainstem, in my opinion, is starting with the foundation. So the reason I say this is a lot of rehab post-injury, it looks at a deficit and then it says, how can we get you better at what you're not good at, which is really important. But if there are underlying neural mechanisms that aren't in place that have helped solidify a good foundation for future better brain building, then you may not be getting the most out of those therapies. So that's where I think the brainstem comes into play. And if you look at the nervous system, especially the brain as a house, the brainstem is the foundation. The last talk I did was on nutrition and sleep. That's kind of making sure that the thunderstorm that came through, all the clouds are clear. It helps sets the stage for better neurological processes, better neuroplasticity to occur. But now the brainstem really helps move things forward regarding rehab. So, like a home, the brain's built from the bottom up. I've said this before. It's also built from the back to the front, which means more of the sensory visual cortex to the motor cortex, the executive function cortex. So, in the brain injury, it's almost like you have this beautiful, serene home, and then all of a sudden, this big old tornado comes through and wipes out the home. Before you rebuild the home, it's important to look at the foundation. This past November, I went to visit a really close friend of mine up in North Carolina, and their family's growing, but they didn't want to change neighborhoods, so they're sticking around in the same neighborhood. And they decided to basically rebuild their entire home just to make it more suitable for the future family. And what happened was when they got the house down to the foundation, they found that there were foundational issues that weren't going to support the new home. So they had to go even further into building their house, invest a little bit more money to make sure that their future home, their new brain, uh, was laying on a solid foundation. So that's where I see brainstem stimulation playing a role in all of this. It gives your brain a solid foundation to build upon. In a brain injury, brainstem twisting can occur, and I think it occurs more frequently than we're aware of. So, when the brain is injured, you can have what's called like a coup contra coup injury. So, there's shifting and movement of the brain inside the skull. That physical movement inside the skull can create cortical damage, so it can create the higher parts of the brain to become damaged, but it can also injure the stem that the brain is sitting upon or the pathways that are ascending and descending through the brainstem to the rest of the body. So imagine you've got like a big brain, we'll say it's a bowling ball, and you've got the bowling ball on a stick. If the bowling ball moves forward or back, side to side really fast, it can cause damage to the stick that's holding up the bowling ball. That's what I see happening in brain injury. So there can be shifting, twisting, rotational forces that damage neural networks between brain, brainstem, and rest of body. That's really important because it can alter vital bodily functions, including heart rate, breathing patterns, and levels of consciousness. So these are just some clinical signs of altered brainstem function in either a concussion or a brain injury. We're working with a few patients who had some severe brain injuries and they're still in a disorders of consciousness state, so it can alter your level of consciousness. The young guy that I worked with, he's about 5 years out from his accident now, but he was in a coma for over 6 months. So it's just amazing to see the progress and to know that, even there's this massive injury to the brain, to the brainstem, there can be tremendous progress if you feed the brain the right type of things that it needs. If you're a clinician and you're listening to this, or if you're someone who's had a brain injury or a concussion, pupil abnormalities can typically occur, and it doesn't have to be pathological in nature. So what can happen is it can alter the way your sympathetic and your parasympathetic, your fight and flight, rest and digest nervous system are working in balance to each other, and it can alter the way that your pupils react to light. So you can have a resting pupil that's more dilated on one side and more constricted on the other. So if you look in the mirror, you can see it's called an anisocoria. If you've got one pupil that's bigger than the other, you can look and see if that's occurring. A lot of times patients will say, yeah, I'm very light sensitive. A lot of visual stimulus just throws me off. There's other reasons for that. But it could be because some of the filter mechanisms that filter light, that filter vision, aren't working appropriately. Another issue that can happen with the pupils is sluggish pupillary reactions, which again could lead to photosensitivity and things of that nature. Sticking with the eyes, you can see this we see a lot in the clinic. And if it gets a little hairy with the ocular motor function, we'll usually refer out to there are eye doctors that work in neurological rehab that can do amazing work with this stuff. But in our clinic, we've got a couple of different devices, different apps on the iPad that we do eye exercises with that are incredible. And I think they work great for some of these things. But, patients can develop double vision for multiple reasons. One being brainstem dysfunction, impaired convergence. This is a big one. I think in almost every single concussion case I've seen, and this is just a subjective clinical opinion, convergence is an issue. And what convergence is basically an eye push-up. When an object gets up close, the patient has a difficult time converging their eyes on the stimulus. What may happen is the patient may be able to come in and keep their eye focused on the target, but the eyes will get weak. It's almost like a weakness in that mechanism. And what that could look like and what it could lead to is having trouble staying focused and concentrated in the classroom, difficulty reading. If you're older, you might notice if you've had multiple concussions, like you're having to pull things away from you to be able to see them and read them, so they're more clear in your visual field. Nystagmus is kind of a fast fluttering movement of the eye, and then a skew deviation, which I won't get into for this one, and impaired vestibulo-ocular reflexes. I would say amongst all of these things, the biggest things I see in the clinic are an impaired convergence mechanism. So there's a faulty eye push-up, which that can be exercised with a very simple, it's called like a pencil push-up or a thumb push-up type of exercise, and then impaired VOR. So the vestibulo-ocular reflex, this is a really important reflex that we have. The way I describe this to patients is if you've ever seen an old movie where they have people running with the cameras, but the cameras didn't have that auto adjuster mechanism on it, the camera's vestibulo-ocular reflex, the screen was shaky. We have an internal mechanism to keep our screen from being shaky when we walk, when we jump, when we run. It's called our vestibulo-ocular reflex. It's a reflex that helps our brain and body do, our eyes and our body do an equal and opposite movement. So that if our head goes down, our eyes will go up. If there's bouncing, our eyes will move in an equal and opposite direction. And the purpose for that is so that we have clarity of vision. I think upwards of I've read papers between like 50 to 70 to 80% of patients with a brain injury or a concussion have a vestibular issue, which that plays a role in, and the vestibular being your balance centers. So next one is vestibular dysfunction. Complaints of dizziness, vertigo, balance issues are huge, and gait ataxia. The reason this is important is the vestibular mechanisms live very close to your cerebellum, and the cerebellum is our balance, posture, and coordination area of the brain. The next talk I do is going to be on vestibular function and cerebellar function. But what's interesting is in a brain injury, you can have cerebellar issues. And what that may look like is something like gait ataxia. So patients will walk with a wider based gait. They may notice that their balance is just off. If they try to turn their head to a stimulus, it throws off their balance, things like that. The cerebellum is really important for inhibiting unwanted movements. It sends a lot of signals to the brain to say, hey, you're doing this, I'll control this. So it has a lot of functions with coordinating the balance centers to the areas for movement and for cognition. That's an interesting one because there's a concept known as dysmetria of movement. So a dysmetric movement is a not smooth movement that can occur after a brain injury. Sometimes patients will say like I'm a little bit more clumsy when I reach for something, if I grab something. That's your cerebellum that's not working good, tied in with your vestibular system. But you can also have what's called dysmetria of thought, and that's a cerebellar pathway to the front part of the brain. And patients will say, "Man, I'm not thinking as clear as I used to think. I can't get the words out. I know what I want to say, but it's coming out all jumbled." They're not able to have a linear thought process. And that might not be that higher frontal lobe mechanism. That might actually be an issue with your balance centers. So what's neat is if you start working on balance, you start working on proprioceptive exercises, patients will say like, yeah, I'm able to like think a little bit more clear. I'm able to get my words out a little bit more efficiently because the cerebellum helps coordinate those other areas of the brain as well. Autonomic dysfunction, and also too, just on that note, vestibular dysfunction, that's all in the brainstem. The cerebellum is an outpouching of the brainstem, so all very closely related. This is a big one as well. So fluctuating blood pressures, alterations in heart rate variability. Typically, health is synonymous with a higher heart rate variability. If you test heart rate variability after a concussion or brain injury, you'll usually see a lower heart rate variability. Breathing irregularities, I think I've talked about that before here. You almost like lose your parasympathetic diaphragmatic deep belly breaths and you shift into more of like a rib cage survival breathing, and it can happen unconsciously and you get stuck in that habitual breathing pattern and you're not getting good deep breaths, you're not oxygenating your brain, etc., etc. Cranial nerve dysfunction. So lots of cranial nerves in the brainstem. I might do a different talk just talking about all the different cranial nerves and how to stimulate them, but we're going to talk about a couple today. So dysphagia, dysarthria, difficulty swallowing and speaking, facial weakness. I see that very commonly and it can be subtle and it may not be pathological, but it can show you like if this is really cool actually. So if it's not pathological, like what I mean by that is in a stroke, a lot of times what you can see is if you know a loved one that's had a stroke or a friend that's had a stroke, there's a change in their facial tone. One side of their face is a little bit more droopy. But in a concussion, if you look in the mirror and you close one half of your face looking in the mirror and then you do the other, or you take a picture of that and look, you'll see differences in your facial symmetry from one side to the other. Lower facial tone could mean a weakness in efficiency of cranial nerve pathways stimulating your facial muscles. The facial muscles are innervated by our facial nucleus. And so, there's a lot of work you can do to help stimulate those areas. We've had a couple of patients with pathological facial weakness after stroke, after brain injury, And doing cranial nerve stimulation can significantly improve their facial tone. It's really cool to see. And that's just from doing transcutaneous electrical stimulation, no Botox, nothing like that. So pretty cool. Altered gag reflex, it could be one or the other. So a lack of a gag reflex, which could mean impaired vagal nerve function, or it could be a heightened response. I've seen both. So that's just something for people to know. Postural instability, um, man, this is a big one. So I'll talk a lot about this in the next one, but difficulty standing or walking, differences in their walking, loss of balance while walking, truncal ataxia, lots of exercises you can do for that. They just lose good truncal tone and coordination. A positive Romberg test, which is having someone stand with their feet together, arms down by their side, looking straight ahead, and you're looking to see if there's sway. You can have them close their eyes to take out vision because vision helps so much with your balance and see how they do without it. That's usually something that you'll see. I don't know if I've ever seen a brain injury patient or a concussion patient who hasn't had like a positive balance test that says, hey, we really have to focus on these balance centers to help get the rest of your brain better, because that's working on brainstem stuff. And then we talked a little bit about breathing, but all different kinds of breathings. There can be some big issues with breathings and with breathing in severe cases. All right, that was a lot on that chart. I just wanted people to have that. So we've talked about nutrition, we've talked about sleep, and those are much bigger and broader areas. But if you're looking at neuro rehab and you're looking to stimulate the brain to recover from a brain injury or a concussion, step one is reestablishing a strong neurological foundation via the brainstem. I feel like I've said that like a million times. So, how do you do that? There's a lot of ways to do that. You can do it with devices, you can do it without devices. I always try to help patients when they're at home to do all of these things without devices, creating an environment that's conducive to vagus nerve stimulation, cranial nerve stimulation, quiet, calm, good brain nervous system stimulation. But we use a bunch of tools in the clinic, so I'm going to talk about that. So you want to balance autonomic function. The reason I'm talking about the vagus nerve and the trigeminal nerve are those are the two main areas I focus on when I'm looking at brainstem stimulation for a couple of reasons. Most of it's like the research that I've read on them. And then also some of the clinical outcomes we've had by doing that type of stimulation. And then also guided meditation, which, it can if you're a super duper awesome meditator, then kudos to you. I'm not. So I started using a device, which I'll talk about. But okay, here's a paper. I highlighted a couple of things I just wanted to share with you guys. So the application of non-invasive vagal nerve stimulation to stress-related psychiatric disorders. So before I go into this, if people aren't familiar with vagus nerve stimulation kind of came to, I guess you could say, like medical market by implanting vagus nerve stimulators in patients who were having drug-resistant epilepsy. So patients had severe epileptic issues, they weren't responding to medications. They would implant a vagus nerve stimulator, and in some cases, they would see upwards of a 50% reduction in seizure activity, which is it's pretty profound. Like being able to do that without medication for a seizure patient is a huge, huge thing. And people people have posted on my page that have the implantable vagal nerve devices, and it's been life-changing for them. The only problem with that is when you have a device that's implanted, you run the risk of infection, device failure, readmittance to the hospital, overstimulation. It's implanted, so you can have an overstimulation of vagus nerve activity, which can cause a whole host of other issues. So the research started to look at, well, hey, how could we do similar stuff but do it non-invasively? So that's what non-invasive vagus nerve stimulation is. And the goal with it is really to just beef up vagus nerve activity. The vagus nerve is our 10th cranial nerve. When I was in school, I had to memorize it for boards, and all I knew about it was it helped us poop and sleep. But it does so much more. It's very, very far-reaching throughout the entire nervous system. The majority of the fibers of the vagus nerve are afferent, which means they go from body to brain. So it really helps establish a strong body, brain, brain body contract. And around 20% of the fibers are efferent, meaning brain to body. So what's interesting is your brain can learn a lot from the signals from your body, but those signals can become disrupted in a brain injury. So you can lose that brain body contract in a brain injury. And a lot of that can be because of damage to the vagus nerve. So the reason I'm saying all this is you can use, even though it's 20%, even though the majority of those fibers are afferent, meaning body to brain, you can use those efferent fibers of the vagus nerve to help try to beef up what's called your vagal tone. So the efferent function of the vagus nerve primarily modulates parasympathetic nervous system function in the periphery, and it acts as a counterbalance to sympathetic nervous systems. The reason that that's important is because, in my opinion, if you look at patients, if you do your assessment on patients after a brain injury, after a concussion, patients can get stuck in, and this can be subclinical, they may not even know it, but they can get stuck in a fight or flight response. And it can look like a couple different things. But the problem with that is if it goes on for too long, it turns into a negative neuroplastic response. So the longer that you're stuck in a fight or flight response, based on the principles of neuroplasticity, it creates habitual pathways and patterns, and it's harder for your nervous system to get out of that. So what vagus nerve stimulation does is it helps try to pull you out of that fight or flight, change the neuroplasticity that's occurring and turn it into more of a positive neuroplastic pathway by stimulating your parasympathetic function. So I think that that's really important. Another very profound side effect of stimulation to the vagus nerve is it's very anti-inflammatory in nature. And I've talked about this in the nutrition portion, but when there is a brain injury, I think at the cellular level, there is mitochondrial dysfunction. And this is a really important concept. There's a guy named Robert Navio, I think that's his name. He's a researcher in California who's studying mitochondrial function, cellular dysfunction, and he, I think, coined the term like the cell danger response. I talked about this in the last one, but when there's inflammation, the mitochondria will go into what's called the cell danger response. They go dormant. And the reason for that is they do not find the external environment suitable to go to work. The mitochondria are either working or they're dormant. There's no in between. So if there's residual inflammation in a concussion or a brain injury, the mitochondria are not going to be working like they should. Some may take the risk and go out there and do their thing, but the the I think the hypothesis is that if there is any lingering inflammation, even if it's subclinical, if it's not showing up on blood work, if there's suspected inflammation, let's say a sympathetic fight or flight response, increased cortisol levels, I'm talking about stuff like that, not like you're sick. But if that's happening, your mitochondria won't work. So with vagus nerve stimulation, you're improving the environment by reducing the inflammation so the mitochondria can shift from the cell danger response to work mode. And when they go into work mode, your brain and body work better no matter what. Less fatigue, better muscle function, better cognitive function, better memory. And it's not something that happens overnight, but that's stuff that can happen with vagus nerve stimulation. Okay, I'll shut up about that. Um, this I'll just read the highlighted parts because I could talk a lot about vagus nerve. So our results from this paper from traumatized subjects without PTSD demonstrate decreased sympathetic, increased parasympathetic tone, which is cool. I think, in my mind, when researchers are using the word tone, that means like neuroplasticity has occurred. You've established new neural networks, new neural pathways to improve brain function. Following acute traumatic stress, suggesting possible translation of this treatment to patients with PTSD. This was without PTSD, but they're looking to work with PTSD patients. So vagus nerve stimulation improves autonomic dysfunction, reducing sympathetic and enhancing parasympathetic tone. Just that alone, just doing that alone for a concussion patient, for a brain injury patient, can have a profound impact on their ability to sit down and read in a classroom, to tolerate sound, to tolerate light, stuff like that. So it's really important. There are lots of ways that you can do vagus nerve stimulation. I've posted a couple times about these, like, listening to different music while humming to the music, doing deep belly breaths, social engagement, stimulating your gag reflex. Those are all natural ways to do it. But what I was really interested in is what can we do clinically to help improve this? So if you type in, if you're interested in this, just go onto Google and type in transcutaneous, so it just means like through the skin, vagus nerve stimulation. And what you'll find is a lot of the research is looking at the ear. So there's something very special about the ear. The ear is richly innervated with a branch of the vagus nerve called the auricular branch of the vagus nerve. Auricular meaning ear. So if you can imagine if like someone just took some paint and splattered it all over the ear, those are branches of the vagus nerve. A lot of the transcutaneous research is looking at this special little area here called the Simba concha. So in our clinic, if we find that vagus nerve stimulation is appropriate, we'll do electrical transcutaneous vagus nerve stimulation to the Simbaconcha of the ear. It's not just the ear though. The auricular branch, it kind of wraps around the ear. It goes down through the behind the ear earlobe area. So you'll see devices on the Googles that are doing stimulation behind the ear here. I'm really interested in wearables. I've been using a small device from a company called Hulist. It's a PhD biomedical engineer. His name's Nick Hool. He was I think like an almost professional golf player, but had pretty debilitating anxiety at some point. And he developed a small portable vagus nerve stimulator that you can use behind the ear. And now he's coming out with these cool headphones, which I'm really interested in. So those stimulate right behind the ear. And then you'll also see handheld devices. There's something called the pulsetto that you can wear around your neck. There's also what's called like the gamma core. That's a little bit more medical grade. Lots of different things out there. We use a device called the StimPod in the office. It's a pulse radio frequency device. It was originally developed, if I'm understanding correctly, for like peripheral nerve lesions, and their research shows that it can help with the regrowth of nerves. And I've seen this little pen do some crazy stuff with like foot drop, with wrist drop, but we use it for transcutaneous vagus nerve stimulation. I also use photobiomodulation therapy. I haven't found a lot of research, just being totally transparent with everybody, on the effects of lasering the ear. But I do believe that, with different types of frequencies, with different light, with different wavelengths of light, you can stimulate the vagus nerve. So I also do use red light therapy, as a tool to help stimulate the vagus nerve. I wanted to show you this paper. So this is a really neat paper. They have a few of these images, and I love when a paper makes some images like this because I'm more of a right brain person, and reading all this on the right side is okay, but then when I can see the picture, I can see it in my head and I'm like, "Oh, that's really cool." But I just want to read this to you because a lot of times when we're working with patients in the clinic, they're like, why the heck are you zapping my ear? Like, this is so dumb. But you have to remind them, like, hey, there's a lot of neurology behind this. And there's a lot of research going into this. And there are some really cool clinical outcomes with cranial nerve stimulation coupled with physical exercise, yada, yada, yada. So I really enjoyed this paper, and I just wanted to share it with you because it shows you projections from stimulation to the ear, and where you can have brainstem stimulation to the rest of the brain. So again, think of it this way. The foundation is stimulated, it's beefed up, and now you have all these great projections going up to help build the scaffolding, the walls, and the roof of the house. So by stimulating the auricular branch of the vagus nerve, it leads to the activation of the trigeminal nucleus and tractus of solitarius nucleus. That's also called the nucleus tractus solitarius, the NTS, in figure A, wherever A is. Oh no, I don't know. I can't remember this one. Okay, yeah, well, it shows the pathway in there. Their activation leads to B, the activation of the locus coeruleus. Okay, there it is down there. So ZAP here, trigeminal and NTS right here. the activation of that lower part of the brainstem, I think that's more of like the pontomedullary area, goes up to the locus coeruleus, which is the higher part of the brainstem. That stimulation will help produce different types of neurotransmitters like serotonin and norepinephrine. The release of serotonin and norepinephrine can modulate global brain activity, which is cool, right? So this is your norepinephrine pathway with projections to, where's my little thing? Projections to the hippocampus, to the insular cortex, to the striatum, to the dorsolateral prefrontal cortex, which is like who we are as a human being, all the way up to our sensory cortex. And then you've got projections of serotonin to similar areas. And then finally, the raphe nuclei, which, oh, that's a serotonin one. Yep. So yeah, pretty cool, right? Like that's vagus nerve, that's transcutaneous vagus nerve stimulation. This paper was discussing the importance of implementing transcutaneous vagus nerve stimulation in disorders of consciousness, which I have a couple patients that we're really working hard with them and we're praying, that this stuff helps them come out of of essentially like their coma. So yeah, I get really it's just great to see that those papers exist. So that's Vegas in a nutshell. And again, we can chat after this about other ways to stimulate the vagus nerve. But the ear, who would have thought, right? I know people that do acupuncture and natural medicine, they probably known that for a long time. But when I found that out several years ago, I was one of the people that was like, no way, that's crazy. This was newer for me. So I used to be all about Vegas, and then the trigeminal nerve caught my attention. So the trigeminal nerve, this is our fifth cranial nerve. It's a little bit higher up in the brainstem. It's located, the nucleus of the trigeminal nerve is located in our pons, which is like the middle part of our brainstem. The trigeminal nerve helps us feel our face. So there's three big branches. So we can feel our forehead, feel our like our sinus region, our cheeks, and then our jaw. And then it also helps with what are called the muscles of mastication. So it helps with chewing. And there's a funny story about this. So I went down this weird rabbit hole about I have a friend. Sorry, I don't mean to go off on a tangent, but real life scenario here. So I have a friend, his name, well, I won't say his name, but he's an amazing guy, but we always go out to eat and he takes forever to eat. Like literally, it's like he could have a sandwich and it takes like 4 hours for him to eat a sandwich. I'm on the other side, like let's eat, let's go do something. So there's a lot of science behind chewing your food. So there's this guy named Horace Fletcher, and he was known as the great masticator. You can look this up. So mastication is chewing, but he you have to read about him if you're interested in this. I did a whole talk on like the science of chewing, but he he would do lectures at like I don't universities, I think like Yale University and stuff on how because he was like such an amazing chewer, it attributed to like all of the amazing things that were happening in his health. And he would go out like he would even say like because he chews, he's stronger than a lot of like the weightlifters at the university and stuff like this. It was just really interesting stuff. So that got me interested in the art of chewing, what happens when you chew. Well, if you actually sit and chew your food, it does a lot, but you're really stimulating your trigeminal nerve, which is really good for parasympathetic function, and for improving overall brain function. So, anyways, kudos to my buddy because I guess his brain's better than mine. Efferent trigeminal signaling feeds peripheral and central parasympathetic activity through the NTS, which is the nucleus tractus solitarius, and then the DMN, which is the dorsal motor nucleus, recruiting the vagus nerve, which helps modulate cardiac performance and systemic inflammation. So again, if you're looking at it from a brain injury from a cellular level. How can we improve overall cell function? Well, we can help modulate inflammation because what that will do is it'll pull mitochondria out of the dormant state and get them back to work. Just one of the mechanisms behind it. This is a really neat paper I just wanted to share with everybody. I think it's a free access paper, but just like the other paper that showed kind of the projections to the brain, this is a paper that shows different projections from stimulation to the trigeminal nerve, the trigeminal nucleus, and what it can do, like the projections to the heart. It can help improve cardiac performance by reducing your heart rate. It can help improve stroke volume and help improve cardiac output. It's anti-inflammatory in nature. It can reduce inflammatory cytokines. It can reduce chemokines. It's really neat when you start to look into this stuff. And then this one also did go into wakefulness and psychological dysfunction. So really neat paper. I won't read a bunch about this, but I just wanted to make sure I shared it. I think it's a pretty recent paper from like 2022 or 2023. So definitely worth checking out. You've got it there. I think you just type it into Google and you're good to go. Oh, the other thing I wanted to say about this. I think I've talked about barrier systems in the past, but in a brain injury, there's research that shows that within hours, up to like 6 hours or less, you can have gut dysfunction, intestinal permeability. Really neat paper from, I think it was like 2007 that showed that in mice. When you have intestinal permeability, that can cause systemic inflammation. And we are only as healthy as our barrier systems are healthy. So if we lose function of our barrier systems, if we lose good gut barrier, that can lead to systemic inflammation. If we bonked our head and it caused that, most likely there's a breakdown in what's called our blood-brain barrier. The blood-brain barrier is like the bouncer at the door. It's only going to let good stuff in, bad stuff it's going to keep out. If there's systemic inflammation from gut dysfunction, it'll further cause reduced function of the blood-brain barrier system. So it'll open up the barrier and bad stuff will get into the brain, causing neuroinflammation. So you get a brain injury causing leaky gut, leading to systemic inflammation. That systemic inflammation can make its way up to the brain and not allow the brain to heal, causing further breakdown in the blood-brain barrier. What trigeminal nerve stimulation has showed is that it can help modulate blood-brain barrier activity and improve blood-brain barrier function. So it can kind of seal it up so the bad stuff doesn't get in, making you more resilient, reducing the inflammation, et cetera, et cetera. So that's why this is important. Because again, it's kind of weird. Cranial nerve stimulation. You're doing a lot of stuff to the face. The trigeminal nerve, the sensory branches, the three sensory branches of the trigeminal nerve, they innervate the forehead, the cheek, and the jaw. So what we do in the clinic is, and what some of the research shows, this is cool if you're interested, type in trigeminal nerve stimulation and brain. People have done research where they put TENS pads on the cheeks or TENS pads on the forehead, and then they've measured biomarkers in the blood to see if it helps reduce inflammation, which it does. So in our clinic, we might have a patient doing some sort of physical activity while they have a specific device stimulating their cheeks. Very low electrical impulse, nothing crazy, but just kind of sending those sensory signals into those sensory pathways, stimulating that area of the brainstem, making that part of the brainstem talk to the vagus nerve, and then do what it does. That's the goal with this, is you're just electrically modulating activity, trying to speed things up, get things to work better. But what the research shows is that it can improve brain blood flow, which is really important. Our brain is a gravity dependent organ. It needs blood flow to go in, oxygenate, send nutrient rich stuff to the brain tissue, and also help get stuff out. Improve blood-brain barrier function, reduce brain inflammation, reduce swelling in the brain, and improve and increase nerve growth factors. This is not a great picture. I could have done a better job. But basically, like if we use a device, I'll stimulate the side of the cheek. Again, it might be while they're doing another activity, but the goal with that, or we'll laser the face, the goal with that is to send sensory signals to the trigeminal system, to wake it up, to improve all those things. And it's not very long, just like what we do in the clinic is typically like 10 to 15 minutes of this, sometimes with other things. So that's trigeminal nerve stimulation in a nutshell. If you've never looked into it, if you've had a brain injury or concussion, worth looking into, because what you're doing is you're building a better foundation to help build a better brain. Meditation. I have some patients that are like before their injury or during their journey of recovery, they've become expert meditators. I was never a good meditator. I find that meditation is hard, which is why I do it because it's hard and you're supposed to do hard things. But meditation is one of the hardest things for me. But I was introduced to the BrainTap device. I really I like the way that I feel during the meditation with this device. So what it does is it's binaural beats. Dr. Patrick Porter, he has his PhD, I think in psychology. But he and his father developed basically guided meditations, and then they got into looking at how light therapy can help. And so it's called like visual entrainment. And they use these flickering light diodes behind that little um, visor, I guess you could call it. You just close your eyes, let the lights flicker through your eyelids while you're listening to a guided meditation. A lot of times I fall asleep doing this, but I've had some wildly vivid experiences with this. I just feel like I can really go into a deeper, more restful, relaxed, meditative state. Like I feel like I'm relaxed, but I can really use the front part of my brain. With patients, what I've noticed the most is memory is a big issue post concussion, post brain injury, short-term memory, most specifically. And I've noticed a lot of changes in short-term memory and cognition when doing this on a regular basis. You know, it's not something that you do all the time. And that's not just this. It's just it's a cool device that you can use. Uh, I say like if you're a bad meditator, it's worth trying. Some patients don't like it. Some patients have their own thing, but I like this. So pretty interesting. They had a paper. Uh, the reason I was interested in this is what they found in their paper that they published on this was there was an increased heart rate variability after doing sessions of this. And like I said earlier, heart rate variability is synonymous with health, well-being, better parasympathetic activity. And so again, my goal with brainstem activation, brainstem stimulation is to pull that system out of a fight or flight response and beef up the rest and digest parasympathetic response. Anything that can help do that, I'll use it. This is my wife. I don't know if I told her that she was in this slide, but we have three boys. So she in this picture was pregnant with our third. She was having it was kind of a stressful week. I forget what was going on. I was busy at the clinic, probably all over the place, and we needed to do stuff, and I wasn't focused. But she came by, and I was like, "Hey, just go lay down and do a brain tap session." She was like super pregnant. Our baby, his name's Crew. He was due, I think, in a week or two. And this was on I'm probably getting my days wrong. This was on like a Wednesday or a Thursday, and she came in, and it was like her whole body melted when she did this. So this is what we do in the office. We have a couple more devices now from this picture. This was over a year ago. This is the Nano V. I love this machine. This company is great. So this is vaporized laser water that she's breathing in through a nasal cannula. It was originally, I think, brought to market for performance enhancement in athletes. Like their website was a lot of baseball players using this. The mechanism of action behind it is that it helps reduce protein misfolding post brain injury, brain inflammation. I've noticed, I love, this is just a side note caveat, but brain fog, clear thinking, just after like 20-minute sessions. I love this thing. At first, when the guys got it for the clinic, I'm like, what is this? Come on, man. And then I started using it and yeah, I fell in love. Anyways, we've got lasers shining in different areas, just kind of giving her a relaxed session. Long story short, I'm not saying that BrainTap got my wife to have our baby, but like she seemed so relaxed. Like a day and a half later, we were at the hospital giving a really great birth to our little guy baby Crew. So cool little picture. That's what a BrainTap session could look like. Okay, so we've talked about cranial nerve stimulation. Another important area that I think needs to be looked into when you're doing brain injury rehabilitation are what are called primitive reflexes. So for people who are unfamiliar with primitive reflexes, the primitive reflexes are a set of stereotypical reflexes. They are survival reflexes that we are born with. They appear in utero and they typically I say they go into hibernation or they're remediated, or they are integrated at like around the first year of life. And the reason for that is if you have a kiddo who had a pretty typical birth, they're breastfed, they're starting to like sit, crawl, stand, all those things. They roll, all those things. They start to hit these reflexes very naturally. They're very naturally integrated in the first year of life. Considering that there has been no major trauma, no like social isolation, if like the poor kiddos, stuck in a NICU or something like that. So these naturally integrate. So if you have a patient who had the normal birth, naturally integrated their reflexes, the reason that's important is the integration of those reflexes, they kind of beef up the brainstem area and they help create a solid foundation for the baby to build a bigger, better brain. In a brain injury, what can happen because a healthy functioning brain puts the brakes on a lot of stuff. It inhibits a lot of stuff. So healthy brain inhibits. When you start to lose function in a healthy brain, let's say for instance, let's not talk about brain injury for a second. Let's say for instance, you have a loved one who is getting older and they have a diagnosis of early onset Alzheimer's or Parkinson's. What happens in those situations is they lose their inhibition. So in Parkinson's, what that could look like is it could look like a resting tremor. In Alzheimer's, what it could look like is outbursts, inappropriate social behavior, things like that. So a healthy functioning brain inhibits. So once these reflexes are integrated in the first year of life and the rest of the brain starts to develop, the brain has this tonic like background firing of inhibition of these reflexes. If you get super stressed out, if you're super duper fatigued, you may have noticed at one point that you startle easily. So it's almost like your startle reflex reemerges because your brain is just trying to shut down and reboot. In a brain injury, these can reemerge. That's the long-winded thing of what I'm trying to say here. When there is injury to the higher parts of the brain, there can be brainstem dysfunction, which can clinically look like reemergence of a primitive reflex. So this is really interesting because again, if a baby is trying to build their best brain, they're naturally integrating these reflexes. These reflexes are integrated. They go into hibernation mode in the brainstem. The bigger parts of the brain develop. Trauma to brain, it can lead to a loss of inhibition, which means reemergence of these primitive reflexes. Why is that important? It's important because if you're trying to walk again, maybe you need to go back and do something before you walked, which is crawl. Maybe you need to get better at doing crawling exercises before you get better at walking, because there are neural pathways that are involved with helping you walk from crawling, right? Crawling sets the stage for walking. So I have lots of cool, like, ah, I'm doing a talk in May this is a very short version of that. Much more expanded, much more clinically focused, lots of case studies, lots of videos. I'm hoping it'll be recorded if you can't make it, but if you can, love to have you come because we've had patients who like they've done hours and hours, sometimes years of therapy and they're walking, but they're not walking efficiently. And all we do are some of these simple things, and all of a sudden their balance gets better, their walking gets better. It's just crazy to see. So I'm not saying it happens all the time, but it's really neat. All right, I'm gonna shut up. I'll read from here. Primitive reflexes are involuntary motor responses originating in the brainstem present after birth, in utero, actually that facilitates survival. Several reflexes are important in the assessment of newborns and young infants. The central nervous system motor responses are eventually inhibited. It's usually within the first year of life, and it replaces them with voluntary motor activities. Walking is a voluntary motor activity that almost becomes like a subconscious motor pattern, but it may return with the presence of neurological disease. Here's a cool paper. This is cool. I think this is done by some physical therapists. So what this chart shows is that based on their assessment within this research, in concussion patients, what they found was that there was a handful of these reflexes that reemerged in concussion patients. One was the Moro reflex, which is kind of like your startle, fight, or flight reflex. The STNR, which helps prepare you for crawling. Typically, it's integrated before you're 1 year old. The ATNR, which helps with kind of like ipsilateral to contralateral movements. The asymmetrical tonic neck reflex. The spinal galant reflex that helps with postural muscle firing, hip rotation, um, all this stuff. The TLR, which this one's really interesting. I've seen this one pop up a lot in concussion patients, and it's never tested. And when you reintegrate the TLR, simple exercises, really simple exercises, their balance gets better, their vision gets better, their double vision gets better. So, and then I thought there was one more, but that must be it, the TLR. And there may be a couple more. Usually on my physical exam with the patients, we'll run through all of the primitive reflexes. But these were the main ones that this paper found. So I thought that was really interesting.
Hey everybody, this
All
is
right, here's
how
a
I
video.
do remediation exercises for the Moro reflex in the clinic in a patient who's had a concussion.
So again, this is for a patient. If they're physically able to do this, this is how we do a remediation exercise for the startle reflex, the Moro reflex.
Or concussion or a brain injury and they're physically able to do it. So I use a Bosu ball to promote extension. And the way we start is we start with rights over lefts in flexion. So kind of like in that flexed fetal position, but right arm over right leg over left leg as well. And I ask them to slowly go into starfish extension while they're inhaling through their nose to promote better nitric oxide production and go into real full extension. And once they're there, they slowly come back in, crossing opposites. So lefts over rights while they're exhaling. And I ask them to do up to 10 reps, possibly 2 to 3 sets, once or twice a day.
If possible, like that's in a perfect world, but that's a really good exercise. Um, the hardest part about that is getting the pattern. You'll notice if you have like a client or a patient you're working with a concussion, or if you yourself had a concussion, the patterning is a little bit hard, but it's a really, really good exercise to do. Okay, here's another one. This is for
Okay,
three. This is how
for
I do three in a
concussion
row.
and brain injury, the next exercises that we work on, if the patient's physically capable, is remediating the ATNR primitive reflex, the STNR primitive reflex, and the TLR. And I kind of created a little combo exercise for that. Again, if the patient is able. So they look like what would be called bird dogs. We have the patient get in the quadruped position, and we're going to do a cross crawl exercise with head turns and gaze stability. So I ask the patient to slowly extend their right leg and their left arm simultaneously with their left thumb sticking out. Now they start in the neutral position, but as the extension occurs, I have them turn their head towards the side of extension with their eyes focused on the tip of their thumb. Then they come back in and we do one STNR, kind of like cat cow reflex, where I have them do a flexion of the neck and extension of the neck back to neutral. And then we switch sides. Then we go extension of left leg, extension of right leg with right head turn, eyes focused on the thumb, and then back to
You could
neutral
just call my right
and
arm a leg.
flexion of the head, extension of the head, boom. And that's one rep. And we go through about 8 to 10 reps, 2 to 3 sets if possible.
I need a haircut. My hair used to be short. That's if the patient can do it. Lots of different ways to do that. That's just, I had a kiddo who I worked with, 16, horrible concussion. She was kind of told by everybody, like, you're fine, all the tests are normal, almost like suck it up. Really, really, really great gymnast. Like she was doing double backflips and stuff like that. That's how she got injured in gymnastics. Straight A student. Um, and we did, so when she came in, like basically by the time she had come to see us, on the medical side, the plan was like, let's just start some like stimulant medication so you can get through the school day, stuff like that. we did our assessment, started having her do these exercises, which in a pretty elite gymnast, this was actually a little bit hard for her to do at first, but over time she got better and her symptoms followed. So amongst all the other stuff that we do for brainstem stimulation, but she's back to gymnastics. She does diving, and that was over the course of just a few weeks. So your brain can change. All right.
Hey everyone,
I
these
think
are
this
snow
last video.
angels to help remediate the spinal glot reflex, which may be present in brain injury or concussion. So there's a couple different ways to do this. In the clinic, we'll modify these if the patient tolerates. We'll add in electrical stimulation to the paraspinal muscles. We may also do these on a vibration plate if possible. But the simplest way to do these are steady and slow. You start in the pencil position, and then whenever I'm doing extension, just like in Moro, we'll have slow inhalation through the nose, making a snow angel, and I have the patient go all the way to the top, and then we go all the way back down and exhale. I always like to incorporate some sort of slow inhale, slow exhale breathing exercise during these because we're really trying to stimulate the brainstem and the parasympathetic response. Um, Doing these on different textures. So if you have like a shaggy carpet at home with no shirt on, then you're going to increase stimulus to the back muscles and you're going to increase the stimulation into the brainstem. If you live in colder climates and you're brave enough, you can get some cold exposure by actually doing these in the snow with a thin layer of clothing on, or if you're brave enough with no shirt on. So really good exercise to help stimulate the spinal glot reflex.
Snow angels, pretty simple. Um, Usually I come up with like I call them little neuro circuits, so they're doing one after the other based on what reflex seemed to be re-emerging at the time, and we work on that. Um, one video I didn't have in there that I really like. Well, actually, no, I'm gonna post it in the cerebellar one, so I'm not gonna talk about it. Never mind. Uh, okay, so step three for brainstem stimulation. So we talked about sensory stimulation, vagus nerve, trigeminal nerve, doing some meditation, looking at primitive reflexes. Uh, I didn't go over tests that you can do for those. I'll show you in the expanded one, but there are simple tests that you can do to test for those reflexes. And then you want to exercise them. And then this is assessing and stimulating other important cranial nerves. So the visual stimulation pathways, eye stimulation. I'm going to talk more specifically about eye stimulation and eye exercises in the vestibular cerebellar talk, and then taste and tongue stimulation. This is really interesting if this is all new to you. So we use a device called eye lights in the clinic. Um, they're really simple devices. So what they do is we use them for a lot of our stroke patients and TBI patients to help stimulate the visual pathways. So following a TBI, there's often an interruption in communication between the eyes and the brain. This is from I think this is from a website from the neurooptometry people that I usually refer to. Studies show that 90% of TBI patients suffer from some sort of visual dysfunction. We use visual stimulation in the visual pathways to help kind of turn on the brain, turn on the brain stem. So the eyelights, this is from the eyelights website. Those eyelights, I guess I should explain those better. Hold on, let me go back. So these are glasses, and you can purchase them if you go on eyelights.com. If you just look around, you can buy it'll kind of tell you like if you have this, maybe use this color. You can purchase different kinds of filtered and colored lenses. But the science, a lot of the science is in this little part right here, which is flashing lights. So this will flash lights on different sides of the eyes. So if it's flashing on the left side of each eye, that's a right brain stimulation. If it's flashing on the, did I say? If it's flashing on the left side of each eye, it's a right brain stimulation. If it's flashing on the right side of each eye, it's a left brain stimulation. But then you can adjust this so it's brighter up top or brighter down below. So there's lights that are intermittently flashing as long as they're safe for the patient, not, active seizure patient, stuff like that. So dopamine's critical to the way that the brain controls our movements. Movement control also involves interaction of many other brain regions, including the top part of the brainstem, which is called the mesencephalon or the midbrain. There's different cell groups, dopamine cell groups that are located there, and dopamine production and something called magnocellular activity. These are like visual cells. They can be stimulated when you're wearing those highlights on the bottom row. So dopamine, if you're looking to stimulate more dopamine, we'll use these for movement, for alertness, for awakeness. We'll have the lights shining just a little bit brighter. It's subtle, but the brain can see it a little bit brighter on the bottom row of those lights. And then serotonin is the opposite, right? So if we're looking to try to maybe help with a little bit of like mood, like variable mood, regulation of mood, help with sleep, different types of like sensory perceptions on the brain, we'll try to stimulate the serotonergic pathways. And you do that by putting the lights just a little bit brighter on the top rows. I won't go into too much more detail on those, but a lot of times if you follow our Instagram page, you'll see patients wearing those while they're doing other activities to co-stimulate the brain. The tongue. This is really so I forget why I got interested in this. I think I just randomly found a research paper looking for vagus nerve stuff, but this paper is so cool. This is the paper where I was like, oh my gosh, it's just so interesting to me. The ear, the tongue, like who would have thought you can modulate brain activity by stimulating them? So I've shared this before, but this was a paper that I believe was published and they used what's called the PONS device. So I think this company's out of Canada. It is electrical stimulation to the surface of the tongue. So there is a specific medical device called the PONS device. I don't use it in the clinic. We use the stim pod on the tongue, but this was a neat paper. So this was this is a case study. What they looked at, there was a Canadian soldier named Captain Trevor Green. He had a severe open TBI. He was attacked with an axe in 2006 while he was in Afghanistan. Ever since that day, he has continued intensive daily rehab to recover motor function. The only problem is he began experiencing some significant plateaus in his physical recovery. And I believe if you read this paper, it's mostly regarding his balance and his walking. So what they began to do with him was they would stimulate his tongue while he was performing different types of balance exercises and different types of walking and gait activities. And what they found was that he was breaking through those physical plateaus that he wasn't able to break through over 12 years out from his brain injury. So this is really important for people because I hate when a neurosurgeon says, "Yeah, if you don't make anything like any recovery in 1 year, like that's your window of recovery. Like you get 1 year, you get 2 year." And I'm like, "How the heck do these guys know?" And I'm not trying to be mean, but like they don't work in neuro rehab. Some of them don't really believe that neuroplasticity can happen. So, when you put that in when you plant that seed in someone's mind, it's like who are you to say that to someone? Like, thank you God for saving their life, but just let the other stuff kind of take over because this paper shows you could be over 12 years out from your brain injury and still make improvements, especially with all the new things coming out for brain injury recovery. We have a patient who is one of my most favorite people in the world. She was T-boned by a train. She's over 10 years out from her brain injury. And this past year, I saw her physically better than I've ever seen her before, like breaking plateaus, breaking through physical and cognitive barriers over 10 years out from her brain injury. So don't count yourself out and know that there's stuff out there that can help. Get off my soapbox here. But all it is tongue stimulation. So people ask, like, how does this work? Well, you're stimulating the brainstem, right? In my mind, you're building a better foundation for bigger, better brain development. This the Pons website is cool. It gives I think that image is from the Pons website, just to give credit to them. But stimulation to the tongue, it'll stimulate the brainstem, and there's also projections to the cerebellum. There's projections to the sensory cortex. There's projections to the frontal cortex. So it's not just the brainstem, but what they say is that the tongue is almost like it's a highway of communication to the brainstem. So I wanted to share that because I started doing this in the clinic. We have a balance device called the balance tracking. It's called balance tracking systems. It's a really great, simple balance test and balance exercise that you can use. It has a force plate, gives you a bunch of objective data, helps you keep track of your scores. But I started using this with patients where like we had to make changes in their balance. That was our main goal. And we did that physical exercise with the tongue stimulation. And I think the combination really did make the change. So a lot of their research on the PONS device, people always ask like, where do I zap the tongue? We usually do it on the front 2/3 of the tongue because that's where the research is. Okay,
Hey
eyes.
everybody, this is the motion guidance device. We recently started using it in the clinic and I love it. I use it for a couple of different things. What we're going to use it for.
Oops, sorry. I'm going to go into more detail on the eyes. I just wanted to say that, but this is to help stimulate the vestibulo-ocular reflex.
Hey everybody, this is the motion guidance device. We recently started using it in the clinic and I love it. I use it for a couple of different things. What we're going to use it for today in this video, I'm going to show you how to do gaze stability exercises to stimulate the VOR, the vestibulo-ocular reflex. And I like it because it gives the patients a point of reference, and it helps with the actual smoothness of the motion. So on the top of my head, I have a little laser, and with the patient either seated or standing, I'll get the
Standard.
laser squared up so that their head is neutral, and then the laser is pointing at the center dot. And what they want to work on are called yes, yes, no, no exercises. So what that looks like is a head motion up to one dot and then back down to another dot in a yes, yes head motion. And then we go back to center, and then we go left to right in a no no fashion. And if you can just look at me so people can see my head. So this is yes, up,
Because you didn't know what yes, yes, and no, no looks
down,
like.
center, left, right, center. And we'll do a couple of reps of that and a couple of sets. And again, that's to help stimulate the brainstem, the vestibulo-ocular reflex, and help coordinate head and eye movements, which may have been disrupted because of a brain injury or concussion.
So the reason that's important, that is that's for a lot of patients that can be a monotonous exercise, but it is so important. So just I spoke earlier about the young guy I got to work with this week, and he has I think like one of the main things we're focusing on is ataxia, and he's got something called the central titubation. So his head kind of goes like this, but he's a horseback rider. So you can imagine like him, and he's riding horses. You can imagine him going on a horse, and if your vestibulo-ocular reflex is shaky when you're going up and down on a horse, your vision is totally skewed because you lose your VOR mechanism in a brain injury. So reestablishing that mechanism is really important, even if you're not a horseback rider, because of the bouncing of from walking up and down. Um, what I wanted to say about that too is that that doesn't have to be done standing, but it's really amazing to see like this guy, he's done those before, but he always did them seated or lying down. And that's cool, but like, in my mind, it's like, let's make this real world. Like you want to be walking more, walking better, doing all those things. I was blown away by how good he could do that exercise. And his personality is, like I'm gonna be the first one to the finish line, so like I want to go. But he was no joke on this laser focus doing it, and you could see after he was done just doing one session that he had better what's called like conjugate eye movement. So his head and his eyes were just moving more smooth. Not to say that, oh, it's fixed, but you know that that little stimulation kind of planted the seed for neuroplasticity to occur. So with repetitive exercise, that VOR mechanism, that vestibulo-ocular reflex will get better, better, better. It's going to help with his balance, with his walking, and then eventually more with his horseback riding. So people always ask, like, this is all great information, but what the heck do I do with it? So what an hour of therapy may look like in our clinic, usually we'll start out, I call it like a sensory session. So Typically, we'll work with patients for about an hour, depending on what they need. So we'll do a lot of that stimulation first, right? If we're really focused, if we're kind of in the brainstem phase of rehabilitation, we're focused on vagus and trigeminal nerve stimulation. Clinically, that could look like doing stimulation to the ear while they're maybe doing some sort of breathing exercise, having some stimulation on their face, some vibration on their face, some lasers in different parts of their face, on their neck to help activate those networks for about 10, 15, 20 minutes. After that, we'll go into more of a physical rehab exercise. So we'll work on a little bit of balance, but also some primitive reflex remediation. We do those exercises, like those can be done passively, which means if you've got someone who can't do this exercise, like a cross crawl activity, which you'd be surprised, a lot of people who are up walking can't do really good, smooth cross crawl activities. We help do that for the patient because sometimes you need passive before you get active, but it'll help reestablish those motor pathways. And then typically we'll end with like a brain tap session on parasympathetic steroids. So we'll put them on lasers. We'll have the Nano V running to help with brain inflammation and kind of just like set the stage for future parasympathetic activity in the brain. So some key takeaways, this is me. I've found, working with brain injury patients is very humbling. Um, and this is an evolving way of doing therapy for me, but I always have to ask myself, like, every single brain injury, every single concussion I see, the patient is so different. Their symptoms are different. The presentation's always just so different. Where do you start? And I truly believe like starting with some of this, with some brainstem stimulation, brainstem activation, you're setting the stage for better neuroplasticity. So brainstem stimulation. And then multimodal sensory stimulation improves brain function. We're going to get into that in future talks. Basically, that means we're just co-activating the brain, blasting the brain with sensory input, um, just to help build a better brain. So that's part three. Thanks for joining me. Johnny, your dog's awesome, by the way, man. The part four is going to be, this is one of my favorite. So I like the brainstem simulation, but cerebellum and vestibular systems, this is probably hands down my favorite thing to talk about. It can get complicated and complex, but you can learn it. It can be simple, and there's so many simple exercises you can do to help improve coordination, to help improve balance. So that's going to be the next one. I don't have a date yet, just because things have gotten really busy, but I will try to do it in the next 2 to 3 weeks. That's my goal. This one went a little further out, but 2 to 3 weeks is my goal. So I really appreciate everyone's time. And just remember, you can build a better brain. You just got to know some of these little key details. All right.